Well, it looks like it's leveled off a bit. We'll start with the information no one cares about first. Anyway, I'm Dr. Carolyn De Benedictis. I am the chair of the APDR Roundtable, and it's my pleasure to introduce our topic and speaker, our topic and organizers for today. So our topic is prepping for the new oral board exam. And our two organizers for this session were Dr. Carol Geer and Dr. Tara Catanzano, and I am going to turn it over to them.
All right, welcome everybody. Without further ado, the structure, we'll talk about the structural of the exam, followed by some prep strategies within residency and the fellowship director perspective. And we'll start with Dr. Desiree Morgan, representing the American Board of Radiology, to talk to us about the structure of the new oral exam.
Okay, thank you, Carol. As I get started here, let's see. Okay, hopefully you all are seeing my slides. Okay, if not, somebody start yelling. So again, it's my pleasure to be here, and I hope to describe for you what the exam is going to look like insofar as we know it now, to set the stage for the rest of the discussions today. So again, thanks so much for having me. These are my disclosures, nothing financially relevant. I am an ABR volunteer. I'm currently a member of the Board of Governors of the ABR from 2018 to 2023, though. I was on the Board of Trustees, and I was the DR, Diagnostic Radiology Vice Chair. And so for the 2 years that we were kind of launching this idea about the oral boards coming back in some version, that was a big role of mine. I have been volunteering for the ABR for a long time. And just so you know, I took the written boards in my senior year fall and the oral certifying exam in June of my 4th year, and I also examined on the ABR exam. So I want to always start with the ABR mission, and this is important because it gives you a big picture. Like, we live in the world of diagnostic radiology, but the ABR does more. So our mission is to certify that the diplomates demonstrate the requisite knowledge, skill, and understanding of their disciplines to the benefit of patients. And if you look at all the people who have been certified by the ABR since inception in 1935, the majority are diagnostic. I want to point out to you all that even though the DR oral exam went away in 2013, these other disciplines have been having oral exams since that time. And in the pandemic, they were converted from in-person to remote. So the ABR is currently hosting remote oral exams, just not in DR yet. So for those of you who may have been part of the old exam, I think it's important to look at that to understand what's new. So the old exam was certifying exam occurred in Louisville, Kentucky. There were 10 categories. You can see them listed here. Those were 25-minute sessions. So 20 minutes went on. There was the first bell. There was 5 minutes to get someone to the next room for the next session. So if they started off in thoracic, then they went to GI, then GU, et cetera, until they went through all 10 of those categories. There were 4 days of testing. We did morning and afternoon exams. And while there was a standardized case set, meaning I was a GI examiner, I had 15 cases for the morning. They were the same 15 cases as everyone examining on GI had. So the set was the same, but the order that you gave them, how you scored them, were left to the examiner. There was a category meeting, and this is important, I think, for you to understand when we get to the new exam. At the start of the week, it was more like an orientation. Here's the book of all the possible cases. And then there were daily panel meetings, and I'll tell you what those are in just a few minutes. So contrast that to the new exam. This will be a remote exam. There are, instead of 10, 7 categories. You can see them listed here. These will be 25-minute sessions of testing, followed by a 10-minute digital transition to get to the next virtual room, if you will. This is going to require 10 days of testing because, as you'll see, we can only do 1 per day. So it's going to be a lot of testing. And as opposed to the old exam, these will be standardized cases and testing format to minimize the subjectivity, because that was one of the concerns for the old exam. In addition, there will be daily category and panel meetings. So if you look at old versus new, what happened is we combined thoracic and cardiac into chest, and abdomen is GI, GU, and ultrasound. Now, it's important for structure to understand that ultrasound content may be in whichever category it's pertinent to. So breast obviously will have ultrasound, MSK will have ultrasound cases, so will abdomen, okay? PEDS content will stay in PEDS, so it won't cross over into GI, for example, and nukes will stay in nukes. Now, with respect to DR procedures. Those will be talked about in the context of the cases. So if I would be showing a discussion of a liver tumor, we might talk about, well, how are you going to biopsy that? So it's that kind of foray into procedures. So this is the crux of the content for the new DR oral exam. It's going to be a sample over the knowledge of the domain of each category. So we can ask anything across the broad range of radiology, but to a generalist level, not to the subspecialty level that our current certifying exams go to. What we're hoping to do with this test is evaluate the skills that we can't do with computer-based exam. That's what CBE is. So finding the abnormalities on a case, talking about differential diagnosis, talking about imaging next steps, just like you would if someone comes into the reading room and they're talking about one of their patients. As far as incorporation of physics, non-interpretive skills or procedures, they'll be in the context of the case. If there's a CT artifact, how could you get rid of that, et cetera? What is safety when it comes to a contrast reaction? And there will be coordination across the categories, which I'll show you in just a minute. Oh, super important, there will be no normals. So people don't have to worry about that. So here is a fictitious exam grid. And I want to take a moment to look at it. This is the coordination of cases that didn't used to happen. For example, if we're looking at this abdominal, MSK, and PEDS set of cases, if we look at in red, osteomyelitis happens to show up twice in the new oral exam, that will not happen. We will see the grid ahead of time. And we'll say, okay, we're already testing that concept in MSK, so PEDS would replace that case. Similarly, if you look at types of pathologies, outlined in the gold are all different tumors. So we can see here that in this abdominal set of cases, there's a lot of cancer. So we might want to decrease the number of cancer cases. So that's the kind of coordination we're talking about, so that we're testing concepts and not testing them, too many times. Okay, I hope that makes sense for y'all. The modality mix, how much CT, MR, conventional radiographs is in there, can also be tracked. And again, this wasn't done with the oral exam of your and DR, but it will happen in the new exam. So if you look at kind of the nuts and bolts, again, comparing old to new, because we're not just falling back into the old ways. This is a remotely administered exam with 7 categories, with a longer testing time and transition. The actual time that the candidate is being tested is about 4 hours compared to 5. The days of testing by necessity, just for the logistics, have to be more than 4. And then the category meetings are really key. They'll be happening with each testing day, and we will be coordinating the cases. So I want to talk about this for just a minute, because I think from the perspective of a program director, it's important to know about the scoring and the discussion of case material and candidates. So category meetings are where everyone who is examining in PEDS or MSK or neuro get together during the day. In the oral exam, it happened just at the beginning. You got your cases, like I said, and then you had the 15 per session, but nothing else was said about them. Currently, the case performance is discussed. So you'll see panels in just a minute, but after everyone's been tested, the GI folks would get together, or the abdominal folks would get together and say, boy, this case on the pancreas really didn't go as well as we thought, and hardly anyone got it right. So you take that into account when you go to a panel meeting. For a panel meeting, that's where each person from a different category goes. So one panel is MSK, neuro, abdomen, chest, nukes, etc. What they receive is the scores that the people write down as they're examining the candidates. That happens in that transition period, those 10 minutes. You write the score, you commit to whether someone passed or failed or was struggling or did great. And then for the panel meetings, you get those scores back and you go around and you say, this person was strong in abdomen. They were super strong in MSK. Oh, they had a problem in nukes. So that's where you talk about their score as far as passing the test. So this is the oral format for a single panel. When I'm talking about panels, this is what I'm talking about. If you look at the color here and follow this person who is letter A, this candidate A would start in PEDS, then the next 25 minutes they'd have breast, then they'd have chest, abdomen, right? The other person, G, would start in breast. You see how it rotates. So 7 candidates in each panel. We start simultaneously across the United States, so everyone starts at the same time. There's a recovery period, which has been really important for the remote oral exams for the other disciplines. Sometimes if there's a technical issue, that may make that 25 minutes testing not adequate. And so we have this recovery period built in so that people can complete this test on the day they're assigned to take it. Super important. And we've had Very few, if any, technical failures because we've built in this recovery period. Then comes that category meeting where the individual folks in MSK talk about the cases, whether something was an outlier case, and then the panel meetings. And then by the end, we've spent 6 hours testing the candidates. And that's why we can't have 2. It would be 12 hours of testing, which would be way too much for the logistics of testing. Now, if you put the whole thing together, here's what it looks like. Each of these is a panel. So if 16 panels a day occur, you can see the number of candidates we can evaluate. And since we have 11 to 1,200 candidates currently being certified in DR, it's going to take 10 days. Now, will not be 10 in a row. They'll probably be over 2 weeks. And whether it involves weekends, we're not sure. And I think the ABR is trying real hard to say what we're not sure about as we develop this. So you know. It's important to understand that there will be conditional passing again. So in the old oral exams with 11 categories, you could condition, that means fail individually up to 3 categories, and you didn't have to come back to take the whole test. You would just come back in the fall to take those 3 categories that you did not pass. In the new oral exam, that number is 2. It winds up being similar from a percentage, but that's the number. And finally, the timing. Currently, you all know the core exam happens after the 3rd year of radiology residency. The certifying exam is 15 months after residency completion. In the future, the certifying exam will be in the second half of the fellowship year, and we anticipate 2 administrations ultimately per year. Who's affected? It's our R1 class. It's about to be R2s. They will be graduating in June of 2027, and the first administration of this test will be, still not sure what month it's going to be, and it will be before June, and probably after February, but somewhere in that part of their fellowship, they will take the first DR remote oral exam. Just so you know, sort of high altitude pictures of where we are. We're in 2024. We have completed writing all the content for the certifying exams through 2027. We are working on the format for the oral exam infrastructure. Next year is when we're going to get the testing format finalized. And I just add this here again to reiterate, some things we don't know yet, but we will be trying to deliver the information as soon as we know it so that you all can help prepare your residents. So with that, I will leave this QR code up. This gets you to the ABR website, which has a variety of things, various slide presentations, frequently asked questions, videos, so you can see now, right now, how it works for the remote administration of the IR exam. I think medical physics is up there as well. And with that, I will stop sharing my screen so we can move on to other folks. And I'll be looking for your questions in the chat, trying to answer them as best I can. So let me stop sharing. Okay, someone let me know if I stop sharing effectively.
You're good, Dr. Morgan.
Okay, thank you all so much.
All right, can everyone see my screen okay?
Yes, Sarah.
Okay, great. So I'm going to give a more kind of high level, how do we prepare our residents for this new kind of exam, recognizing that a lot of our early career faculty never took the oral exam. And so there's a lot of concern, I think, about how do we prepare them and ourselves to do this. My disclosures that are relevant to this are that I am one of the deputy chief editors for Rad Exam, and I'm the current president of ACER. So I'm going to touch on the old days, which Desiree gave us a view from the examiner and functionality perspective, but I'm going to talk a little bit about how we used to prepare for it. The next generation of learner preferences, teaching old dogs new tricks, and that's all of us, and then some suggested next steps. So let's look at the old days. How many of you guys remember being like this as the exam taker? We were struggling to try and find time to do all of these things so that we felt prepared to take the oral exam. We were eating up textbooks like there was no tomorrow. We just kept reading and reading and reading. We used the ACR film teaching files. You remember those things, the silver line stuff that you actually had to hold up to a view box. We also used what was pretty novel at the time, which was the ACR disc cases for case exposure. And we did a lot of page flipping where we would take books closer to the exam, look at the images, look at the captions to just reinforce the common appearances of common diseases and some uncommon presentations of common diseases. Aunt Minnie was a must, and so everybody read that textbook. And we had a lot of hot seat conferences and board reviews. Very nerve-wracking. What about the teachers at the time? What did they do to prepare us for our exams? Well, there were a lot more didactics than I think there are now, probably. So that was really to build the foundational knowledge for our learners. Remember that the generations who took the oral exam were much more used to having information spoon-fed to them in a didactic format than our current learners are. There was a lot of workstation pimping, and I know that term is not allowed anymore, but that's what happened. So you were shown cases at the workstation. You were asked what the findings were, what the diagnosis was to give a differential, and that went a little bit more intense as we got closer and closer to the exams, mostly instigated by the exam takers because they were very anxious. There were a lot of case conferences during the day. So generally, a lot of programs replaced their regular noon or morning conferences with case-based conferences specifically for the board takers, generally after, the first of the year or sometime in February or March. There were after-hour board reviews and, of course, our Aunt Minis. So case conferences were, for those who have not experienced them in this format, they generally were unknowns where there was very little or some clinical information provided for the case. And then you could either go round robin, we used to call it pass the pointer. She had a laser pointer and you would point it at the findings and discuss the case, or you would give multiple cases to one trainee at a time. The goal of those case conferences were that the trainees were taught to tell what the type of the exam was, CT of the abdomen and pelvis with oral and IV contrast, demonstrating whatever. They then went into the salient findings of the case. They were taught to be very narrowly focused, not to mention negatives unless they were pertinent, and to really focus on the findings there. They were to provide a differential diagnosis, and then they also gave management suggestions or next steps or other imaging that were going to be required. The early board reviews, generally the ones in the first part of the calendar year, were more educational. There was feedback provided for their case presentation skills, their knowledge. They were given tips and some teaching points. Later on, closer to the boards, when everyone just wanted to see more cases, more cases, more cases, everything was given in a rapid fire and there was really no teaching. So how do our new generation feel about that? This is clearly not going to work anymore. They're going, oh my God, no way. So my opinion on this is that this generation of learners, because of the way that they learned in school and the way they were brought up, they really do prefer just-in-time learning. They do not want to be singled out to take cases in front of their peers or their colleagues. They don't want to take cases in front of the group. They prefer on-demand learning, meaning that they would like to have small video vignettes that they can learn at their own pace and their own time and go back and re-review. They want things to be interactive, but very technology-driven, not necessarily in person. They have no experience with oral forms of testing or really oral presentation because we've moved away from them taking these kinds of cases in public. So that's really a challenge for them to do this. And they've really honestly dictated fewer and fewer cases, so they're really less comfortable describing findings. So what do? I think what we have to do is we have to ask for their input. How do they like to learn? What's their preferred format? Are there any electronic or AI solutions that they know of or would like to develop? And how do we increase their comfort with public case taking? I think that one's going to be a big one. We really need to meet them where they are, which involves moving us to teaching us new tricks, right? So this is the way we used to do it. And I think we really need to shake it up a little bit. Some of the ways that I've done it and that I've heard other people doing it is by secure texting them some interesting cases. I used to do this little game with first years where I would send out a patient's name and case number on the secure texting. And I would say the first person to get me an answer of what it is and describe the findings gets a candy bar. And so it became gamified and it was more fun for them. And I got a lot of engagement early on. Gamifying, I think, is a way to go with them. Case conferences, maybe in an asynchronous format. I think we're going to have to morph some of the way we do that. On-demand board reviews are probably going to be more likely than the after hours. They're not really interested in staying after work. Frankly, I think we aren't either because of the pressures of everyday work. And Aunt Minis are going to be important as well. So just to wrap it up, some suggested next steps. I think it's very important that we create a culture of psychological safety, and we have to destigmatize making public errors. They're really afraid of this. We have to make it safe for them to do it. They need to practice their case-taking skills. We need robust boot camps on presentation skills and case discussions. I think if we do these things in small groups that maybe they self-select so that they're around people that they're comfortable with, maybe we'll get to some of that culture of psychological safety sooner. And then I think we're going to need to look at AI solutions. The platforms I don't really know what they're going to look like. As I mentioned, that I am one of the associate deputy chief editors for Rad Exam. This is something we've talked about, and I'd love people to put in the chat if this is something they would like Rad Exam to develop. Maybe a set of these types of cases that would be appropriate that people can then use their own institutions. I've heard of some societies who are trying to develop some of these offerings. Again, I'd love to hear if people know that they're going on and put them in the chat. Industry is probably going to step in and start to produce some things that they see a market for. And then if anybody here has any idea on developing offerings, please let us know. I think we really have to move from the Flintstone era to the Jetsons era and really meet these learners where they are. And with that, I will stop.
Right, I am sharing my screen, always the most intimidating part of these things. Can you all see my screen?
Yes.
Yeah.
Yes.
All right, great. So Tara is the ultimate setup woman here for someone to follow. And she's already talked with about some of the ways we might want to approach strategies. I'm a residency program director. And for disclosure, I took the oral exam. And so I have experience in that, but I didn't take the core exam. And I think that we have to remember, we are, those of us that took the oral exam, we're prepping people that took the core. And the one thing about the core, I'm kind of a glass half full kind of person. I'm sort of, okay, things are good. And I look at this and saying, gosh, we are going to start prepping for the oral exam after people have taken the core. And the core is actually great for getting residents to kind of pull in a big knowledge base. And once they're done taking the core, which is right now, they actually are carrying around a lot of information in their heads, which I think is a good starting point for oral exam prep. I think right now, when our current R1s are about to be R4s, I think that is, we need to start thinking that may be the best time to start intensive oral exam prep before those penguins that they've sort of put in their brain start kind of falling off the iceberg, if you will. So I say we, program directors of residencies, we need to really think about taking advantage of this core exam situation right away. And if you take nothing more from what I'm about to say, I think we need to start thinking of plans for oral exam prep now. I think that we can consider starting oral exam board reviews in July of our R4 year. I think we need to start thinking of a regular schedule. We don't want to get to these folks R4 year and say, oh gosh, I guess now we need to start thinking about this. I'm going to throw out some ideas that, based on, Tara talked about, this generation, they don't super enjoy being on the spot in front of a whole lecture hall full of people. And I'm not really sure that's how we practice radiology anyway, and that you may want to think about doing oral boards with only the R4s, and maybe starting with faculty who took the old oral boards and working with faculty who didn't take the oral board exam. So I'm going to throw out there just a sample oral exam prep plan following the core. This is not to say this will work for everybody's program, okay? This is just an idea, but the point being, everybody in their own program setup should start to think now, how am I going to do this in my residency program? And this is kind of what we're probably going to try to do, some iteration of this at Wake Forest. So starting in July, every Tuesday and Thursday from 12 to 1, our R4 class is going to have oral exam prep. We're going to start in July. We're going to go through May. It's going to be about 46 weeks, taking in some holidays and things, take about 4 weeks away from the year. Well, you think about that, that comes to about 92 oral exam prep sessions. We're going to do kind of each section has 2 sessions a week. So if you're neuroradiology, you'll have the Tuesday hour, you'll have the Thursday hour. And, it kind of works out to about 12 to 13 oral exam prep sessions per section. And again, this is just an idea. This will not work for everybody, but it's at least a plan. It's at least we're starting to think here. It also may be a little bit too aspirational. You could say this is wow, that's a lot. But even if you cut it in half and you did 1 a week, you're still doing 46 total oral board exam preps and 6 to 7 per sections. That's still pretty cool. That's pretty good. And we're thinking to do it just with our 4 class. Now, what's the advantages of that? One is it's going to be special. I know that sounds corny, but it's going to be special, something special for our R4 residents, special time with them and faculty. And by doing that with just their class, they may feel a little less on the spot. They're a little more comfortable with their class and taking cases and sort of verbalizing it. And, we're always talking about ACGME stresses this. We talk about this at AUR is sort of providing level specific education. And this is really a way to do this. I mean, this is high level board prep with people who've taken the core is going to be very level specific for the R4s. Disadvantages of doing it only with the R4 class. Okay, so we're planning to do these at noon. It kind of works in our workflow, but we also do our regular residency didactic conferences at noon, which means our R4s are going to miss some of those. In our program, a lot of those conferences are probably a little more heavily geared to the R1 to 3 knowledge base. You can judge that as you will. So we're not sure. We don't think the 4th years will lose that much by not being at those conferences and being at these noon board preps from 12 to 1. That's our thoughts about it. Some other disadvantages, you're using some faculty resource here. You already have your faculty giving didactic conferences, and in our place, it's at noon. Now you're asking people to give board prep as well, and we're going to work through this. And again, this is not to say that this would work in everyone's program, and it's kind of you do you, but the point being, we're at least coming up with a plan that we think could have some real advantages educationally, as well as getting folks ready for the exam. As Tara mentioned, there's additional resources and strategies are going to be out there. I mean, having residents take cases in conference, starting early in residency, starting to do that. I think people are talking about, they're going to be online, electronic resources coming. Rad exam is, working on things. I think they're going to be courses, they're going to be boot camps, and those things developing. But I think as residency program directors, on a large level, I think it's on us to get our R4 residents ready to take this exam by the time they're done with residency, because we want fellowship to be fellowship, what we all know as fellowship. And so I think we're going to put a lot of effort, and I think all of us need to think about, again, what works in your educational plan, but put effort into getting our residents ready to take the oral exam when they leave our program, so that during fellowship, they're really just reviewing and they can focus on their fellowship experience. So with that, I'm going to hand it over to Dr. Scott Wuertzer for the fellowship perspective.
All right, thanks, Carol. Let me share my screen. Can everyone hear me, see me?
Yes.
We good? Okay. So as Carol said, I'm going to give the perspective from the fellowship. And I've been a fellowship director in MSK at Wake Forest for the last 10 years. I'm also associate residency program director. I've been in that role for the last 12 years. So just a little bit of disclosure. I don't have anything financial in that sense, but I have spoken with multiple fellowship directors, residency program directors, vice chairs of education, DIO, and even ABR. And the reason I did that was just to get what I thought was sort of the landscape out there, to be sure that I wasn't coming at this from my own little bubble or just kind of an off perspective. So I did reach out to quite a few people. And so in terms of the fellowship in our perspective, there's some concerns, and I'm going to address some of those, and then I'm going to come up with some strategies to address some of those concerns. I think the biggest thing, the most contentious thing has certainly been timing. When is the test going to occur, and how's that going to affect the fellowship? I'll get into that a little bit. What's the focus of the fellow going to be like during their fellowship because of the oral boards? Is there going to be a diluted experience because of the fellowship? Is it going to be watered down now because of oral boards? What's the motivation now for choosing a fellowship? I think some of these things could start to shift over time. And so I'm going to get into some of those. The timing is probably the biggest thing, as I said, and this kind of x-axis here is going to sort of set the tone for my entire talk. I think if you think of the different timing options that were out there, 1, 2, 3, 4, it could have been at the end of 4th year. Most of the program directors are pulling their hair out over that one because you've got 2 different classes, and trying to get them through the core, trying to get them through oral boards just doesn't work. So that was a pretty hard no there. In terms of 2 versus 3, I personally much prefer 3 over 2. 2 is just too early in fellowship. You're just trying to get your bearings at that point. Doesn't really work. 3 versus 4, again, I think practices, private or academic, probably gave some pushback here. And so where did we end up? Well, we ended up at 3 here at the end of fellowship, or kind of the second half of fellowship. And so, again, most people will admit, ABR will even say it, you know, this is sort of the best of kind of bad options, and we're just trying to pick a spot. But is it really just a spot that's based on convenience? Or are we really doing what's ultimately best for the individual trainee and overall our profession? I know that's kind of a bold statement, but I think it's at least worth talking about. But we are going to go with 3 at this point, so I'm going to address some strategies here at the end. What does the focus of the fellow look like in terms of the fellowship? Well, without oral boards, your focus, I think, is something like this, where it starts pretty high and you try to maintain it, but it's almost impossible to maintain that focus at the full level, because then they're going to start interviewing, they're going to start getting ready for their job, you're doing credentialing. So there's always a little bit of drop off. But you drop oral boards in there, and there's no way that they're focused on their fellowship for the entire time. Again, there's going to be a tremendous dip there. And so the counter of that is where you're going to have some sort of spike in getting ready for oral boards. And so I think there's going to be these wide swings in sort of attention, or what you're trying to accomplish, at least from a fellowship standpoint. I think there's a potential to have a diluted experience for your fellowship. I mean, without oral boards, I can attempt to offer something like this in terms of the fellowship, where it could just be, for me, an MSK, could just be MSK all the time. Again, whether it's scholarly activity, research, again, it can be all MSK as much as I want. Now, admittedly, there may be a need to have some electives, and I'm okay with that. If a fellow comes to me and wants that, that's fine. But again, this looks very similar to the focus. You drop it in the middle of fellowship, and what happens to that overall experience? Well, they're doing less kind of MSK rotations, for example, and they're doing more electives. They're trying to get more time off to start studying. It's almost assuredly going to happen. And so you have a little bit of a diluted experience. I think there could be also a shift in motivation for choosing a fellowship. I think people could be looking for a slot where they feel like, oh, I'm going to get more study time in that fellowship. And so all of a sudden here, fellowship B may start to look better than fellowship A. So what's going on with fellowship B? Well, fellowship B has more time off. It gives people more of a chance to do electives, more of a chance to get out there and study, basically. So the curve for fellowship B is here. So that may be a reason that people choose a fellowship, and I don't think that's a great reason. Resources. Let's see, more resources. So again, this is another point. So what do I mean by that? Well, that's kind of a broad statement, but let's say that fellowship B is bigger than fellowship A. Well, fellowship B has more fellows to throw at the problem. So in other words, they're going to be on call less. They're going to have potentially taking taking fewer MSK rotations and doing more electives, more study time. Fellowship B is also likely paired with a residency, which I think is key in this whole process in terms of just kind of maintaining your skills as you move towards oral boards. Fellowship A may be also paired with a residency, but I think it's really the bigger fellowships that are going to sort of thrive in this situation because they have more resources to potentially handle some of these situations. And so that may be a reason that people choose one fellowship over another. So what are some strategies? Well, I think we need to kind of try to flatten those curves, that green curve, that blue curve. And the previous two talks kind of addressed some of that. I think it's critical what you do in fourth year. And so really, as a fellowship, you kind of try to need to maintain the knowledge and skills from residency. And so I think overall, there's going to have to be some sort of change in the traditional mindset, both from the fellowship and from the residency, or this doesn't work. At least it doesn't work in terms of the timing, in my opinion. All right, so this is what I showed earlier in terms of the focus and those kind of ups and downs. Fellowship, focus is way down. And what do we really want to do? I really want to see something that's much more flat in terms of these curves, where again, you're going to have a little bit of a spike, this blue spike here for oral boards every time. But again, it's much more flat. So how do you get there? Well, you look at the fourth year, and as Carol said, when you're coming out of core, your radiology knowledge is going to be high. And it may start to drop a little bit as you move through fourth year, but that's not going to do anything in terms of the focus of the fellow. I mean, those curves are still going to be way up and down. So what is going to flatten those curves? Well, something like this certainly isn't. So if you go through fourth year and you don't have any practice in taking oral cases, which is kind of where we are now, that does nothing in terms of these curves, in my opinion. So you really want something like this, where you start early in fourth year, you get them kind of gradually better and better at taking cases, and hopefully the radiology knowledge stays high. And so when they hit fellowship, they're focused on fellowship, and so these curves are much flatter. I actually think 3 is the best situation here, where they come in with a little bit of oral skill-taking abilities already, and that has to do with the residency and how you do things early on. So to me, this is sort of the optimum situation in terms of these different curves. Now, the big black box, though, is what happens here in fellowship for these 8 months. I mean, the idea is that we're supposed to keep the people at this point. If they're coming in as a 1 way down here, there's no chance the fellowship is getting these people up to this point. So that's a pretty hard task. So I still think you need to kind of continue to take live cases, practice doing oral things. So how do you do that? Well, the fellowships, I think, are going to have to pair with the residencies. They're going to have to tap into some of the tricks and techniques that Carol and Tara talked about previously. If you don't, then the fellowships aren't going to be able to do this on their own. So you already have attending to resident, hopefully happening in residency. I think there's going to be a need for something attending to fellow. That may be a tall ask or a tough ask for the attendings here to try to do a lot of things for the fellows. I think that's going to be tough. I think this can be a you scratch my back, I'll scratch yours kind of thing, where the fellows could show cases to residents. Again, that may be a little bit of a tough dynamic to sell as well, but I think it's a possibility. This is one that I like even more. I think the fellowships are going to have to kind of combine together and realize, we're all in this together. This goes back to one of Tara's points, where I think it's more likely that a fellow might want to show cases to a fellow and be more comfortable in that situation. So you can use, let's say fellowship 1 is mammo. So fellowship 1 decides 1 week to show cases to fellowship 2 and fellowship 3. Let's say fellowship 2 is MSK. They decide to show cases to fellowship 1 and fellowship 3 the next week. So there can be this sort of exchange between the fellowships. Again, I feel like you've got to continue to show cases and get the people continuing to talk out loud to, at best, sort of maintain these curves as you move through fellowship. And even this, I think, is kind of a tough ask. I mean, this person down here at a 1 that got nothing in residency is never going to make it. They may have a little spike if they're sitting in their room trying to grind through cases at the end, but they're not going to make it. And so I think that's sort of still a black box, what happens here for the 8 months of fellowship. And as I said, you're going to have some sort of change in mindset, where the fellowships are going to have to adopt that, where they're pairing with other fellowships, they're pairing with the residency, as I said. But what if what if they don't? You know, what if the fellowships say, this was never my gig? You know, I have no intention and don't have the skill set or the infrastructure to do this, to take one from here to here. Then you've got a problem. Or they may even say, you know, I can't even maintain this curve from here. And so then you start to get curves that look like this, and that's not great. What if the residency doesn't change either? And then you're still down here with one, and that's a problem. Or what if the residency does say they change, but they don't? And so you really have residents coming out that are about at this level, but there's no way of proving where they are at this point. So oral boards, I know this is not going to be this is not going to be popular, but I'm still wondering about oral boards at this point, because I wonder who owns the trainee at this point. Because let's say that the best residency in the world gets their trainee to this point, and then everything starts to drop off in fellowship. So does the fellowship get blamed for that? So who's taking ownership of all this? There may not be that much motivation for the residency if there's no test at this point, because the residency that's operating down here is going to say, well, we really did have them at that point, and they just failed during fellowship. They failed as a trainee. And so ultimately, I think in some ways it does a disservice to a great residency, because the residency that gets their person to this point wants to shine, wants to show that. So that's why you have oral boards at this point. It feels like you're training for something. You get to this point and then you decide, hey, let's take 8 months off and see if it works out, see if they can maintain that to that point. So again, I know that's not a hot take. I would wonder about oral boards as a better position back here. I get it. It doesn't work in terms of the two classes. It's a logistical nightmare for residencies, but I just think in terms of kind of the overall thought process, doing what's best for the individual trainee, I would wonder about oral boards at this time. And then it really does let you just focus completely on your fellowship at the end. And so that's all that I had. And thanks for your time.
Thanks, Scott. So we have a lot of chat action, and a lot of it, Dr. Morgan, I think, is going to be obviously the optimal person to sort of kind of address some of these questions. And I'm going to turn over to you, Dr. Morgan. Are there a couple questions you feel strongly need to probably be discussed before this?
Well, I just want to say thanks to everybody, because it's super refreshing to hear the different perspectives, and in the chat for people who are contributing kind of what things are happening there. I guess, and we certainly heard and contemplated putting this exam at the end of residency again, and even core in fall. I mean, and then oral exam in spring. Everything was on the table. I want to get us back to what we're doing when we send a resident out into fellowship after graduation. We are saying, as program directors, I'm a former program director, they are ready for independent practice. Technically, they're good to go, right? And so it makes sense that, well, why aren't we testing them then? I want everyone to think about first opportunity. The timing of this test, when we're talking about, oh, it's going to be in the fellowship, that is the first opportunity that a resident has to take it. They could actually wait until 3 years into general practice to take it. You have 6 years from the time you take the core to take the certifying exam. So how about you just go into independent practice? This is what ophthalmologists do. This is what peds intensivists do. This is what neurosurgeons do. And a lot of their boards, they have to have a certain number of cases. So I'm not comparing that, but I'm saying general practice would be a great way to take a general certifying exam. Now, one of the complaints we heard from the stakeholders in practice was that with the way that we were testing, focusing so on subspecialty, the residents and fellows were getting to a practice able to do only what their fellowship was. They couldn't cross cover, they couldn't remember anything. So I think Scott's points about keeping that, trajectory going, that's what's really going to help the public. Think about the mission of the ABR. Our test is to try to help, the public by certifying that everybody that comes through the process and and is certified by the ABR is ready to practice. The contribution of the educational environment, all the ACGME things, everything that a program director is attesting to is another thing that you all are talking about. How do you make that environment one that's conducive to passing this test? But I would argue to practice. So we had some chats, people were talking about their residents give multidisciplinary conference. Remember, the old written exam was very different from the core exam. There weren't very many pictures at all. We were asking like, what is, Werner Morrison syndrome? Things that weren't really high level radiology. The core is almost all images. So you're already looking at higher Bloom's taxonomy of looking at things. So we've got that down. We have tests on the broad range of diagnoses in radiology. What we're trying to test with the core exam is, can people talk about cases? They should be able to talk about cases at the end of residency. They should continue to talk about cases in fellowship, especially if they're presenting at conference or if they're moonlighting. I don't think people are going to lose it as much as we think they are. I think we need to give them a little more credit for maintaining knowledge. Think about when they're rotating currently as residents and they haven't been on breast for a while. They come back to, is it like learning new again? No, they build on what was there before. So I don't think I really answered a question. I just want people to think about the concept of first opportunity. Maybe the best way to prepare for this is to go into practice. We don't know that. It'll take years to figure that out. But I think we need to give them more credit for retaining things. I think the fourth year is going to get much more exciting than it's been. They've been checked out after core, waiting to go into fellowship. And what you do to help them, I think, you've got board review going for third years. You can have peer learning for board review for fourth years. Whether you're fellows, fellows should be fellows. Like I'm speaking as a vice chair of education. This is not the ABR stance. I'm just telling you, someone that works with learners at all levels. Fellows are going to have to work as fellows. So, and what's going to be refined then is their ability to communicate, and that's what we want to test on this. So the knowledge base is going to be there from the core. Hopefully they're from their residency. You're testing that they're ready. What the fellowship doing is making them more mature in a certain area, but more mature in talking about cases as well.
I think that Scott brought up one of what I think is an elephant in the room that I am kind of worried about as a program director. I'm interested in people in the chat, people on the panel. Even though we're going to say all this and hopefully we're going to have them ready by the time they go to fellowship to, I think we will have them ready to take cases. I feel very strongly that we have good residencies out there and the residents are going to get a lot of practice doing that. But you're going to get into fellowship and you're not going to think about breast if you're a neuroradiology fellow. You're going to be intensely studying neuroradiology. You're not going to be kind of thinking about breast. And I get your argument that, well, maybe you should be if you're going to practice breast but abdomen for that matter and all the other specialties. So what the reality of it is there's going to be a stress level there for the fellows who are going to say, I've got to, make sure I'm studying and staying abreast of this. And the ABR is probably thinking this is a good thing, and it probably is in some ways, but it is going to be stressful. And I worry that the elephant in the room, that there are fellowship programs that are maybe offering more study time and these sorts of things. I get a little bit worried. Will that come into residents' choices on fellowship? Scott did mention that, but I'm just throwing it out there. It's probably a very unpopular thing to talk about, but I'll take the chance. Thoughts from either the chat or from the panel on that?
I think some of it though is about shifting mindset, not just for us, but for the trainees. I think we have to really, that's why I think it's so important to get them involved as stakeholders, because they're coming at all of this from a very different lens than we are. We're coming at it from the lens of, we've all been in practice. We know what it takes to be, a practicing radiologist. We've been hearing all of the kickback from private practices who say that, the people who are coming out now aren't necessarily coming out with the robust skills that they need for general practice in smaller community practice settings, right? So we're coming at it from that lens. but they're not. So I think it's incumbent on us to try and help them get there. And how we do that, I don't know, because I think we need to learn to communicate with them on a different level than we have. And I have robustly failed on this completely. So I'm not a good person to help figure this out. But I do think we need to help them understand that these are skills that they should keep, because even if you put it into the basic economic terms of your job may go away at some point for whatever reason, or you may need to change practice settings 15, 20 years into this and have to relearn skills, and shouldn't you have developed them earlier on so that they're not new skills as an adult learner who's really focused on whatever their subspecialty area is. So I think we need to help get them there to understand that these are lifelong skills that we're trying to give them, and it's not just about being so super focused, that they really should try and keep up, obviously not highest level of reminding what their breast imaging was or whatever, but at least competency and familiarity.
Yeah, and I'll add to what Tara was saying. I put in the chat, I think there will be no way to avoid the fact that there's going to be stress around this exam. It's an exam, and there's going to be stress. And I think this panel all took the oral exam, and this panel, we were stressed. I'm going to own it. I was stressed. I was worried. I'd studied so hard, but I was still panicked. Because there's a lot in radiology, and you're worried, am I going to get caught? And when you took things after the fact, you're like, okay, that wasn't that bad, but beforehand, we weren't like that. We were worried. So I think that's where during fourth year, it's going to be really important to get them a lot of practice taking oral exam experience. I think program directors and residencies, we have to own this big time. We're going to ruin their fellowships. I hate to be melodramatic, but we just have to live in the real world. They're going to be stressed thinking about this exam. The other thing, I think it's going to be important that the residency programs, as we're doing oral exam prep for our R4s, that we bring the fellows in. And allow them the opportunity to participate in that too. I think that could be a really important thing.
Can I make a pitch? I know, Carol, that you had said to put the fourth years off to have this really intense kind of thing preparing for oral exams. Our case conferences never went away. And I think it's super important for first years to see third years and fourth years take cases. And it is hard when you've got a whole bunch of people in the room for people to have enough turns to do that. So I think that's what you have to manage, but it should really start at the beginning. And it can even start with daily teaching. Like everyone has different ways that they receive information from residents. Some people just pour things into queues and you're looking at it and you only correct them if they're wrong. With first years, I go over there and they're presenting the case to me. It's like we expect what Tara was describing. What are the observations? How do they synthesize it into a diagnosis? What are the pertinent negatives? I know they've got a checklist over there because we all do, structured or standardized reporting, but to think about a case that way, that starts in first year. This is a 4-year prep for the oral exam, as far as I'm concerned. The fellowship is just, for me, really important to gain maturity. Everyone has a different runway of where they get there. And so I hope people aren't learning to take cases in their fellowship, because that's going to be a problem for them to keep a job. In my humble opinion, this is a first through 4 year.
100% agree.
Yeah, I agree, but I do think that for us to sort of say we're not going to do intensive board prep in our 4 year, I think you should. We still have case conferences as well and have people taking, and I think that's why I put it in there. You should do that, but I'm just advocating that for their confidence levels. I think that, and this is one program director's opinion, but I do think it needs to be offered, as opposed to not offering anything at all other than that until the end. Just one person's opinion, but I agree. I totally agree, Desiree. It's got to be a 4-year process. We not just we give didactic conferences and all of a sudden fourth year, okay, everybody, let's start taking cases now. I completely agree with you. It should be longitudinal.
I 100% agree as well. And that's kind of what I was trying to do with my purple curve there and the three getting them a little bit higher. I respectfully disagree in terms of the 8 months that you're getting when you get into fellowship. I feel like that's just a maintenance time. I mean, that's really not doing anything in terms of measuring a metric, in my opinion, other than whether or not they can maintain that baseline, which you could argue is important. Yes, we want them to kind of develop that. And then you could argue, well, let's just have it way out in practice if that, and these have already been stated. So I don't know, the timing and dropping it into fellowship, I don't feel like that's really doing what in terms of kind of measuring something different. It is measuring, okay, can they maintain a skill? And my graphs may have been way off. I'm not expecting them to completely drop off, but again, I just feel like why not just have it at the end of fourth year? You're measuring what the residency is trying to do. So
Can I raise something about the timing here? So in this first cycle, the very first exam has to be not in the fall of 2027, because that's when the folks graduating in 2026 will be taking their old cert, right? After that, the ABR anticipates that there will be 2 times of the year where this exam will be given. One will be in the late spring, let's just call it late spring. Again, please don't hold me to this. You saw the big project plan. It's not been decided. But opposite that will be another administration. It could evolve where people started taking this in the fall of fellowship. Now, you could argue that's not good either, because they get there, they need to hit the ground running and start. But if it equaled out, my one real concern with this, and this is the provocative part of the statement, is, I mean, I hope we don't give people time off in fellowship to study for this test. That would be disaster for the workings of the departments. It would not send the right message, in my opinion. Again, I'm talking as a vice chair of education, not as an ABR trustee, governor, volunteer, anything. I mean, at some point, you can't do that anymore. So who's gonna really ride that bull and have those hard discussions?
The other controversial thing I'll bring up, because this actually came up when I was a resident taking the oral boards, and we had fellows who had not passed their oral boards and wanted to come to our board reviews, and it was a resounding no from my class because they didn't want them taking cases away from our turns. So I just wonder how we broach that subject with residents when these are fellows. I think they'll be fine with the people who trained with them and are the year ahead and stayed on for fellowship. But what about the newbies, and how is that going to go down? I think we have to be prepared for those kinds of conversations and a little bit of conflict with that.
Carol, there was one question at the beginning that I had written would be good for everyone to hear. Maybe people were looking at the chat. We talked about per category, how many cases would there be? We're hoping the minimum would be 8. It depends on the dynamic. We will be prepared for at least 15, but probably people won't get that many. But there was one question. So talking about being a neuroradiologist would not, obviously they're not going to have chest review or anything like that. I mean, I guess, and we were addressing this, I think, through the rest of y'all's conversation. So I don't know that we need to talk about that again. It will have to be a team effort if you do that. But how about the asynchronous time? Like Tara was saying, let people practice that way as fellows. They'll just have to find time. I mean, I know we all just have 24 hours in a day. We make hard choices with our families and everything else. That we'll never get more than 24 hours in a day. I just think that chairs are going to expect people to be working as fellows, best I can predict. And so how we help them maintain is going to be a challenge. We've got a few years to try to figure it out.
So in the interest of time, we're right at the 1 o'clock hour, and we obviously were not meant to solve any of the world's oral board exam questions in this, but we did want to throw out thoughts, get folks thinking. Not all things that we all put out there were meant to be agreed upon by the group, but to throw out, and the chat room has been extraordinarily active. This recording will be available. Tara can also enter in, but I want to really thank Dr. Morgan, Dr. Wuertzer for you all's perspectives. I think you all were the headlines for this and put together some really great discussion for us all to start thinking about and talking about in this next year. And it was really helpful to me as a program director to hear from you all.
Thanks to both of y'all, Tara and Carol, as well. This was
Yes, thanks for having me. Can we also save the chat? I think it's really important for that
Yeah.
feedback in the chat to be heard by
Great.
the.
Yeah, thanks.
Yes, yeah, Carolyn, we'll save the chat, correct?
Yeah, we saved the chat, and also I saw someone asked if we can post the recording. There is an APDR roundtable page, correct? I think, yes, there should be, Skylar, right? There
Yes,
should be an
correct, from my
APDR
understanding, yeah.
page where we see is from my memory, unless I'm losing it. So we can save the chat as well as post the recording for all of those program directors that would like to see it afterwards. But thank you, everybody.
Yeah, thanks, everybody.